shock.
That's a 1.
Did I hear Greg say 2?
No, 1.
Okay.
Identify the, oops, hang on, we're missing what are we missing? I need to turn the phone back on. Oops. Technical difficulties here. Hang on, just a minute. Oh. Thank you, Brandon.
Yep.
Like I said already.
So while they do that, I'm going to read you what we have as the pathophysiology of shock. Acute widespread reduction in effective tissue perfusion, invoking an imbalance in oxygen levels, leading to anaerobic metabolism, lactic acidosis, cellular and organ dysfunction, metabolic abnormalities, and if prolonged, irreversible damage and death. And that is, in fact, the pathophysiology of shock. The question is, do we need a multiple choice question about that? If they know that shock is basically impaired perfusion, inadequate perfusion, that might be enough, right? They don't necessarily need to know the pathophysiology for our purposes. Doesn't mean it shouldn't be covered in the class they take, right? It should, but so that's why I gave it a 2 or a 3.
I would agree with that.
The 4 types of shock.
Definitely a 2 in my mind.
Everybody good with that? Okay, 3 phases of shock.
I almost see those as ones, 1 or a 2. It's understanding that especially irreversible means basically irreversible even in the hospital, although you might get really lucky. And the difference between compensated and uncompensated.
Everybody good? Okay, signs and symptoms of shock.
1.
Definitely. Ones.
Okay. Purpose of primary and secondary survey in the list, and list what to assess in the primary and secondary survey.
So this is the one where primary survey is basically your ABCs plus consciousness, and secondary survey is everything else. So it's really, because of the way that we work, it is rare that we come upon a scene where we have to think of it in terms of primary and secondary survey. The example I use when I teach my students is she goes into you come into the house and you spoke with her an hour ago and you get there and she's laying on the floor, In that case, you're going to do a primary survey, airway, breathing, cardiac, and level of consciousness. But that is I've never even experienced that in 45 years, So knowing the difference, that's why I put it as a potential 2, but I'm fine with it as a 1 as well. And then secondary survey is everything else, which is really what we're doing: pulse rate, respiratory rate, blah, 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 all the numbers, the history, all of that is secondary survey. So given the nature of our work, what do you guys think? 1, 2, or 3?
I think that the primary survey, you're right, is not something that we're typically really engaging with. I guess I'm struggling a little with why to separate them and not just ask a question about the whole assessment sequence, like survey sequence.
This is a standard kind of a division of the information. And
I think it lends itself well to an emergency response like I do.
Right.
Where we conduct a very defined primary and secondary. But given this interaction, it's kind of just a conversation with the individual. And in that process, you're looking at their level of consciousness. You can tell if they're perfusing well just by skin color and level of consciousness. So I don't think the dividing it out lends itself well to what we're trying to achieve here.
Putting it in the course, though, I think is useful to help people understand that there are levels here of seriousness that, you know, you could encounter where you would want to do this. But in terms of the test, I'm not sure. And then taking your idea, Colleen, and trying to figure out a multiple choice question about what to check, you know, level of consciousness, maybe pulse rate, you know, all the things that when we look to assess for shock, I just don't, I don't know. I mean, I'm open.
Well, if we're going to stick with this, then, you know, I think since it's kind of broken out in the competencies and in the education, then maybe the primary survey just being a 2 and the secondary being a 1, if we're going to keep it this as 2 separate surveys.
Or we could make it one question.
I'm thinking.
Well, explain the purpose of a primary and secondary survey and list what to assess.
So, and that was my question. Are there going to be 2 different categories, the purpose versus what to assess? Or do we want
Purpose
to?
has to do with exactly what Greg was talking about, which is coming upon a scene and needing to establish rock solid baseline, right? Versus already being there and noticing it happening as you are managing it.
So
You know, the number one cause of shock that we see is postpartum hemorrhage. In general, that's not something you just walk into, right? You've been there the whole time. I mean, it's possible, and can, I'm sure it has happened, but that you miss the birth and you show up and there's blood everywhere. But, you know, it's not really the usual thing.
So is everybody good with this level right here, the 2 and 1?
Yes.
Yeah, sure.
Okay, explain the locations of palpating a pulse.
Those make great 2 questions.
I think so.
Good.
Okay. Explain the relationship between pulse height and systolic blood pressure.
I find that a super useful tool because pulling out a blood pressure cuff and dealing with that is often not a great thing to do when you're handling a postpartum hemorrhage with a brand new baby and everything else going on.
I agree. I definitely would appreciate the person that's able to assess a person's blood pressure by observation and palpation rather than dragging out a blood pressure cuff.
Exactly. And you know if it's this level that you've got this kind of a systolic, and that's not good. You know, so, you know, it's not telling you an exact blood pressure, it's telling you when you were in serious trouble and you need to be doing stuff. So to me, that's a 1, but I'm okay with it not being a 1. It could be a 2.
I see head nods. 1's good to go.
Yeah.
Fine.
Okay, list and define the 3 levels of care in the treatment of a patient in shock and their components for basic, emergent, intermediate, and advanced.
So advanced is using medications that we don't have and skills that we don't have.
Right.
Basic is basically, it's anybody can do it. You don't need any special equipment at all. You can use, you know, your shirt to maintain, you know, to keep them warm. Intermediate requires things within our scope and advanced does not. So that looks like people really like, well, I don't think that advanced is no.
Oh, okay, sorry.
I think that just because it's not within our scope doesn't mean we couldn't have a question on it. So maybe have, it looks like everybody agrees that it's important on all of those. So I would make at least the first 2 1s and maybe advanced rehabilitative a 2.
Sure.
Sure.
Okay. Explain what the special positioning needs are for a pregnant woman in shock. Everybody agreed and it looked like you wanted a 1's good?
Mm-hmm.
Okay. Explain rational and physiology. Oops, I'm sorry, what?
311, I think, is supposed to say rationale. There's supposed to be an E after the end of the AL. So the answer to 3.10 is, you know, lay her flat and lift her up on the right side. And that's the special positioning needs. And then the rationale is, why are we doing that? And that's where the vena cava comes in. That could potentially be one question. So
Yeah, I
or-
think that if we're making it a mandatory question, just one question is probably sufficient.
Yep.
Yeah. So a combo meal there.
Okay.
And it might make it a little easier to create multiple choice questions to have more than one factor in there, you know.
Okay. Actually, I don't want to say. Okay, 3.12, explain the reasons for using IV therapy for prevention of treatment of shock. A 2, everybody good with a 2, or change your mind?
I get live with it too.
Okay. Explain what equipment is necessary and why when administering IV fluids.
I gave these a 2 because we're going to have this equipment already at the testing site. They're not having to pull it together themselves.
Skills, yeah.
On the skills test. But
It seems really excessive to have a question about each of them, though.
exactly.
Yeah.
So maybe give a 2 to the top there where it says explain what equipment is necessary, and then we can figure out how to word a question.
Yeah.
Yeah, it's
Okay.
gonna be a thing.
It doesn't it seem like it's just covered in the skills though? Like,
Well, but we're not asking them to bring the supplies with them to
right.
the testing site. They're all going to be provided at the testing site.
I mean, in the past, the way I've seen it done is that the supplies are all in one like localized area, and then part of the testing is that you go and gather your supplies, which of course are all in front of you, but they'll also be in front of you at a birth potentially.
That would require us to have things that are not necessarily needed for that test at that testing site. So she could be getting her IV skills at one place and getting their meds by injection at another place and their suturing at another place. So
Yeah.
it really worked well when we had supply closets that you just pull what you need out of it. Or
That's
have
true.
a big pile of stuff. But we can't expect every testing site, which could be just a midwife in an area who's doing this, because we're providing them with which is another thing we need to figure out, is who's supplying these supplies. And I'm assuming, is it the student who's supplying the supplies? In which case, Colleen makes a good point. They have to bring all the things they need. And if they don't have everything they need, they can't do the test.
Mm-hmm.
So, Cynthia, how are we handling? Are we sending out little kits to testers that have everything in it that they need to do the testing? Or are the
No.
students providing it?
Let me look at what the skills exam says. Hang on just a second.
It has a list of what's needed, but it doesn't say who provides it.
No, it doesn't. But that's something, let's see.
It doesn't address it anywhere that I'm aware of, Cynthia.
I don't think it addresses it either. No. Well, we could add that in, that the individual must bring the supplies to perform.
But they're going to have what we've told them, what we've said is that we're going to give a copy of the skills exam to the candidates. We don't care if they have the list of the steps. We want them to know what the steps are. They just have to be able to do it without looking at that form, you know. But as a study guide, absolutely, we're going to give them a copy of the test. That's what we talked about doing, and we're planning to do, as far as I know, for the skills test, not the written test, but the skills test. that's available to both the tester and the student ahead of time. So it says right on there what the supplies are that are needed.
Mhm.
So if we're not going to ask a question about, I mean, I'm okay. That's why I gave it a 2, is like, I'm okay. I mean, and not everybody's going to have an IV pole hanger, or
It's true.
whatever. I think most of these things are pretty straightforward, but.
Right.
So I could go either way. I don't think it should be a 1, but I could go with a 3 or with a 2. It would be a hard thing to make a multiple choice question about, though. Thoughts?
Do we want to try, leave it as a 2/3 and see what we can come up with?
Or do you think we need it at all? Colleen is I'm hearing Colleen say she doesn't think we need it at all. If they can do the skill, they've got the stuff, they know what they need.
I'm in agreement with that. They can do the skill. Yeah.
Okay.
Okay.
I love
Okay,
making
explain
things.
appropriate care.
So this looks like 4.2 is 1 or 2 questions. Each of those doesn't need its own question.
Yeah, and then I think 2's on, 1 on the expiration date, though, you're right.
I gave 1s to expiration date and color and clarity.
Mm-hmm.
This feels like it could be one question that encompasses all of it, maybe.
Yeah, that's
Yeah.
what I'm thinking. And it would be a 1.
Mandatory or a 2, a roll-in?
A 1.
I think a 1.
Mm-hmm.
Okay. 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 Okay, the difference between the following solutions.
2.
I like that, yeah.
2 on each, or kind of a, I guess.
Yeah.
Okay. Frustration flows to treat shock.
So the key elements here are the Trendelenburg, because she's in shock, don't sit her up. The AC site, because you need as large a needle as possible, easily accessible, and you have loss of fluid, so it could be harder to get a vein on there could be some vasoconstriction. The larger gauge, if possible. The GBS prophylaxis is not for treatment of shock.
That doesn't even need to be in there.
That goes somewhere else.
This comes out completely.
Mm-hmm.
It needs to go somewhere, but not there. So that all seemed pretty important to me. Looks like it's a relatively new question. At least the breakdown is.
So 1's on all of those except this one, which needs to be moved somewhere, but we don't know where, Holly?
Not yet.
Okay. 4.6.
Yeah, that's where it goes.
Under here.
Yeah. There's more to it than just that, but that definitely will go there. Because you also use a saline lock. So 4.5.
Oh goodness, I don't know what happened here. So we're
Yeah,
gonna make it a 1.
4.5 has
Why isn't it deleting my
has
stuff?
2 bullet points plus the instructions. So a lot of this, Cerinthia, the way that if you look at the specifics that you sent out earlier with all the details, we had the steps being 3. I had steps being 3, which aren't on here. And I had for 4.5, the rectal administration of fluids alternative to oral hydration, blah, blah, blah. I had that as a 2, and I had using a prepared enema, follow instructions on the product as a 3.
Oh,
So there were 2 bullet points in 4.5 under explain and describe, and then we put instructions for rectal administration of IV fluids. And we have a specific list of things to do, which isn't covered anywhere else. It's not on the skills exam. So we were wondering whether it needed to be a 2 or a 3.
on this one, the prepared enema.
4.5. Yeah.
Yeah.
So those are those two things, rectal administration, prepared enema. Those are from the learning objectives, the bullet points under 4.5, where rectal administration is an alternative to oral or IV hydration. I'm kind of inclined to give this whole, the 4.5 3s at this point. What do people think
I
about
like
them?
that. Mhm.
Yeah, I think that's
I feel
fine.
good about that.
But then on the 4.6, it's a 1
4.6.
for the GBS that we just did up here, which is,
Yeah, it's going to have that. You can use a smaller needle. You can use a non-AC site. And those are the 2. Oh, and you need to use a saline lock.
Mhm.
Those are the 3 kind of things that go under 4.6.
okay. Okay, so flow, describe appropriate flow.
So are you going to
rates for-
capture those? So do you want to capture those 2 other things?
Oh, I'm sorry, what did
So
you
you
want me to
got the
capture?
GBS. I don't see the saline lock. And it doesn't need to say for quick infusion. Actually, get rid of the quick infusion because you're not worried about getting it in quickly. So it's an 18 to 20 gauge needle is fine. Non-AC site is fine.
Non what?
You got it.
It's a cube. Yeah. I see.
And acute site, SITE, is okay. And use saline lock or establish saline lock or whatever. We can fine tune that later.
Well, I guess since this is a test, oh no, that's fine. You know, I want to go back to the discussion of Trendelenburg. Has that fallen out of favor for the management of shock?
Just raising their feet. As far as I know, we still do that, but we're worried about if she's still pregnant, getting off the vena cava.
Sure.
Is that something that you are noticing? Not raising the feet?
Not only in pre-hospital medicine, but in the hospital as well. It's just fallen out of favor. I mean, I head
What's
down.
the evidence for it? What's the rationale? Other than it's a pain in the butt.
There's been cases of it's caused stroke, and yeah, I don't know.
Raising their feet, huh? And this is for shock.
Right.
I'm looking at it. Yeah, look at this.
For hypovolemic shock. I can research it, in which case we might want to change it. I'm making myself a note on a piece of paper that right now is escaping me, but I will find it. Trendelenburg question mark? I mean, that might make sense for cardiogenic or restrictive, but I'm wondering if hypovolemic it still applies. But
Says it can increase intracranial pressure, increase cardiac stress, and reduce ventilation.
Particularly in the gravid woman, it can affect respiration.
Mm-hmm.
How high are they elevating these people's feet?
We used to hang them from the roof because we thought it worked.
Mm-hmm.
Point to the sky.
So are we adding something to 4.6?
Yeah, you just put it in yellow.
No, something else that you're researching?
Oh, that's different. That's up above. That's Trendelenburg.
Oh, that's up under the
Trendelenburg.
Trendelenburg.
So,
So you'll let me know, Holly, if we need to change anything on there.
and if we do, we'll change it to supine, laying down. Sounds like we probably will change it, but I just want to do my due diligence.
Okay. All right, so we are down. Okay, so that's good. We'll do some rewording on that one a little bit, and then we're on flow. Describe appropriate flow rates for IV administration.
That looks like it's a 1.
A 1. And then list reasons why IV flow can be impeded. Looks like potentially a 2.
I think that's important in our setting, that it be included in the bank of questions for sure.
The next one, everyone said yes, but it was a 2.
What do you think? 2 or a 1, you guys, on signs of infiltration?
It's pretty elementary, but it's also very important.
Yeah.
I think 2 is fine.
I agree.
Okay. List risks associated with inappropriately placed IV.
Like you can kill her if you do it wrong. We have down for that things like infiltration, hematoma, air embolism, phlebitis, extravascular medication in system, stuff like that.
Yeah, I think it's important.
You want a 1 or 2?
I would say 2.
Okay. Okay, list 3 aspects of IV fluid to check before administration. And it looks like everybody said yes, and we got a 1. Okay, list actions to take to prevent infection when administering or changing an IV. This needs to not be and. Everybody, well, 50-50 and a 2. We good with a 2 or? Okay. Describe what to monitor while administering an IV and immediately after. 2. Everybody good with that still? Demonstrate appropriate steps for administering an IV for prevention and treatment. And then all of these are 3s because it's a practical
And that's because
application.
we're on the skills exam. Exactly.
Good with that? Oopsie.
We're getting close, you guys.
Getting there.
Really close. You just got to finish suturing.
I think that's NQ.
Oh, it is. Thank you. No change. Well, thank you.
I'm sure you would have figured it out.
Oh, I would have. Oops. And my computer isn't really working with me today.
If we're having this much trouble with the computers without and artificial intelligence, I can hardly wait for the kind of brawls we're going to have when we have AI on board. It's going to be, no, I insist. You must do it this way.
Yeah, when I have it highlighted, I can't see that it's highlighted, but Brandon can see it highlighted up on the big screen. He's like, no, you got it. Just hit paste. And it's like, well, I can't. Yeah, it's
I
weird.
have no idea what's happening here.
Yeah. Okay. Explain basic female pelvic floor and genital anatomy.
So in the past, some people have tested on tests for this by having things pointed to with arrows on illustrations, and that turns out to be not a great way to actually know if people know where things are, because pictures are not the same thing as the thing. So just to say that it is a hard thing to actually test for where it is, but this is asking for explanations, and we have things like perineum, external area located between the vagina and anus. Those are easy to write questions for because you just put that definition and then you list 4 things and one of them is correct. So those seem like great bank questions to me.
Everybody good with that?
Sure.
And again, many thanks to Desi for pulling all of that together and coming up with great definitions.
Yes, I'm sorry.
I vaguely remember that. What was that, 2 years ago?
Yeah, right.
It was about a year ago. Más o menos.
Okay. List methods for preventing perennial damage when indicated. Everybody said yes with a 2.
Sure.
And define degrees of perennial damage. We're on the border of 1s and 2s here. What would we like to do?
I think
I say ones.
ones.
I agree.
Okay. When performing a perineal exam to determine the need for sutures, what additional conditions or injuries should you evaluate for that may interfere with suturing? Everybody said a 2. We good?
Mhm.
Okay. Explain the
She's like,
steps
we're going to be
evaluate.
done by 4 o'clock if it kills me.
We are almost done.
I know.
Okay, explain the steps to evaluate pelvic floor and genital area for damage following birth. We're on a 1 there. Okay. Circumstances when perennial damage may not require repair. We're 1 or 2. Oops. Well, we don't need 11. 1. That was kind
1 or
of
2.
2, maybe.
2. Okay, list the types of perineal damage which requires transfer of care.
1.
1.
Okay. List the types of perineal damage which should be considered for transfer of care.
1.
1. Okay, explain the consequences of a poorly done repair of a perineal tear. 2.
You've destroyed her sex life forever. It's all your fault. So guilt is one of the consequences.
2's good? Okay. Explain pros and cons of local anesthetics, amide versus ester base. So the pros of amide, the cons of amide, the pros of ester, and the cons of ester.
So here's the problem with that. And this is understanding the pros and cons of local anesthetic is separate from amides versus ester based. Those should be 2 different sets of questions. So local anesthetics as a group, whether it's an amide or an ester based, have pros and cons. So we could all think of, swelling and misalignment and blah, blah, blah. Then the difference between amides and esters aren't about pros and cons. They're about what is the difference between them. So somehow that got conflated into 2 questions, into 1 question, when in fact it's 2 questions. And I didn't realize it until I've been looking at it.
So it should be explain pros and cons of local anesthetics, and then a second question that says explain the difference between amide and ester.
And the problem is that in our learning objectives, we looked specifically at the types of drugs that we use that are amides versus esters, and the pros and cons are based on that. So basically, we looked at the difference between lidocaine and novocaine. But there are esters that these pros and cons in our learning objectives don't apply. They don't meet those criteria. And the same thing with the pros and cons on the amides. So I think that's where we got into trouble. This is reflecting exactly what the competency says, but it's a little bit misleading the way we worded it. And I'm sure that I had a heavy hand in that. And so I accept full responsibility for that. I'll add it to my guilt pile.
So Desi, what did you say? Explain the pros and cons of local anesthetics. And then what was the other one, the amide versus ester?
I believe it was explain the differences between amide and ester based, which I don't know what those are. So I'm probably not a good person to help with that question.
So one is excreted by the liver primarily, and one is excreted by the kidneys. And so thus one tends to be excreted a little faster. But yeah. So
those would be our 2 questions.
If you don't know the difference and you're an awesome midwife, maybe it's not that important to know the difference between an amide and an ester, it occurs to me. Doesn't mean it shouldn't be in the competencies. It should be in the competencies. That should be discussed, because if you're allergic to one class, you might not be allergic to the other because they're metabolized completely differently. So if you're allergic to Novocaine, that does not mean, and you learn that at the dentist, that doesn't mean that you're necessarily going to be allergic to lidocaine, although you should be aware that she has that sensitivity to Novocaine, right? So she may be tetchy. So that's why it's important that you know that there's a difference between different kinds of antibiotics, I think, or excuse me, anesthetics.
Mm-hmm.
And that's separate from knowing that using an anesthetic can cause swelling of the tissue, could cause, if you don't bolus it evenly, you know, that you could have uneven alignment, that it may not work, you know, that all that stuff. So it needs to be at least 2 questions, one of which is explain the pros and cons of local anesthetics, and the other is, if we decide to include it, why is it important to know the difference between an amide and an ester-based drug, if we want to include it,
I would do a 1 and a 3 personally.
for those 2 divisions.
So a 1 on explain the pros and cons of local anesthetics, and then a 3, no question on the why or explaining the differences.
I like that.
So I'll just take this whole new line out then. And we'll just have the 1, and then we'll cross this old 510 out, and this will be the new 510. I'm sure all the numbering is going to be different, but oops, hang on. Brandon has a quick question over here for me.
Just notice that on the competencies 5.10, it's still the consequences.
Yeah, I don't know that we want to change the, we may need to change the competencies. So I'm going to put a big note.
Never mind. Disregard.
Okay.
Disregard. Sorry.
I'm sorry, what?
Cynthia, we may need to change the way that 5.11 in the competencies is written. So I can work on that with you if you want. Anybody else want to volunteer to do that? Okay.
What are we doing? What are we doing with that, Holly?
In 5.11, we're going to have to rework the competency a little bit to align with this. So I made a note.
Okay. Okay, so in regards to the question though, 2s on each of these or 3s, or
Where are we now?
we are on 511, explain the pros and cons of epinephrine and
Well,
local
that's not the
anesthetic.
one we're rewriting. I'm sorry, I messed up. My numbering is different than yours. It's the 5.10, I guess. I'm looking at it. I have the old competencies, and so the numbering is a little different.
Okay, so on the explain the pros and cons of the local anesthetics, that one, Holly?
Yeah.
Okay.
That's the one we're gonna have to redo.
Okay, so on this one, the pros and cons of the epinephrine and local anesthetics.
To me, that's a 1. Why epinephrine should not, excuse me. 511 to me is, the most important one is 5.12, why we shouldn't use it for local anesthetic.
That's all I think is necessary. I would say the other 2 are 3s, and then that.
Ooh, oops.
Oops.
Okay, everybody good with that? Moving on. 5.13, explain the use of approved local anesthetics, including
so
routing.
5.12 is a 1.
Yeah, we got it.
Well, I didn't see it. It was underneath something when you
Oh, my little control.
your little control thing. I was like, where'd it go? Okay. 5.1.
And then 1.3 is a 2. Everybody good with a 2, or you want a 3 on that? Explain the use of approved local anesthetics, including route administrations.
I think 2 is fine.
Okay. 5.14, explain equipment needed to effectively repair 1st and 2nd degree and labial lacerations.
So this is like the one we did up above for
Yeah.
IV. And this
So
is
we're going
all
to have it for practical application, right, for the testing.
Right.
So we're just gonna do a no question on that one.
I'm okay with that.
Mhm.
Okay.
Because that they're
Explain it.
definitely going to need to bring their own equipment and stuff. So
Mm.
So is that something we want to put on that skills exam as a requirement that the candidate must bring their own supplies to ensure that they, like a checklist kind of thing?
yeah, they should have their own, especially their instruments. I wouldn't want a suture with some strange, weird, cheap instruments, like this, which is what if the state was providing them. I'm guessing they're not going to go buy, you know, highest quality German stainless steel.
But what about the, like, for example, Holly, one of the things that you said is not everybody's gonna have one of those poles. Is there something where we should have, like, these are must-haves versus, but you have to have the pool, so I
No,
guess maybe.
I've never had an IV pole at a house. Trust me, you got a lot of pictures on the walls and a coat hanger. You can hang an IV anywhere.
Over
Okay,
a
very
door.
good.
Yeah.
Okay.
But
Lamps, doors, you got all kinds of options.
Yeah.
so
I
we
mean-
can do the same thing with this, Corinthia, like sterile drapes, sterile gloves. You know, then you need a needle driver, your needle holder, your scissors of some sort, but they don't necessarily have to be suture scissors, you know, blah, blah, blah. So we can go through this and what they need to have. Not everything is on this list that we originally talked about. Oh, there's the tissue forceps. They're down there. Anyway,
Okay, so 5.15,
but this might be where we can include things that aren't on here at this point, although they're kind of on the skills exam, but an instrument in each hand has been OSHA requirement for almost 20 years now. And lots of midwives don't get that. And that's why we have the
Lots of
tissue forceps.
OBs don't get that, Holly.
Yeah. But you notice that who does get it? Surgeons. Surgeons get it. They use the needle, unless the needle is covered, unless you're not dealing with the needle. They always have an instrument you can. The worst I've seen actually are CNMs. They're terrible about it.
Uh-huh.
Are we on 5.15?
5.15.
Yeah, yes.
Yeah.
Yes.
Okay.
Okay, explain the differences between synthetic and organic sutures.
I think those are twos.
Twos.
Agreed.
Okay, explain the differences in needle size and the most appropriate use of each.
Yeah.
Where's
Twos.
the 310 on 5.16? That should be 3.0, not 310. We have a random one.
Okay,
Mm-hmm.
and then these are all twos as well.
Well, hold on, I'm looking here. What? So the 3.0 gut or synthetic is one thing, and then the 2.0 gut or synthetic, or the 4.0 synthetic is another thing. So this is not matching up. We need more lines than we have here.
Oh, yeah, I see what you're saying. Mm-hmm.
It's 3.0 gut or synthetic, 2.0 synthetic, 4.0. So there's a typo in the competencies.
Is this one supposed to be 4.0 here?
So it should be 3.0. It can be then be 2.0. So get rid of the 2.0 synthetic up above on 5.16. It's just say 3.0 gut or synthetic. And then it should say 2.0 gut or synthetic. 4.0 synthetic. We don't really recommend gut for fine labial repairs. And then, so just 4.0 for, so 3.0 is for most vaginal perineal, for most genital repairs.
Is 3.0 for gut and synthetic
Or synthetic.
or
gut
synthetic?
for most vaginal, for most genital repairs.
And then what about, what should 5.16 read?
Hold
Should it
on.
be the 2.0 on that?
So 5.16 could say, that way they're in numeric order, 2.0 gut or synthetic for deep perineal muscles or lateral vaginal wall injuries.
Perineal muscles?
Or deep perineal muscles or lateral vaginal walls. Basically, 2.0 is for rectal, anal, not even for deep perineal muscles, really. When we say deep muscles, we mean the rectal sheath, basically.
I don't know if that's right. So 2.0 gut or synthetic for deep
Yeah, the word FOR,
for deep perineal muscles or lateral vaginal.
injuries, vaginal injuries.
And then 3.0, would it say the same thing for the deep perineal?
No, 3.0
No.
says for most genital injuries or most genital repairs. 3.0 is what you usually use. And then I would actually change the 2.0, instead of saying deep perineal muscles, I would say anal, rectal, or lateral vaginal injuries. So
On which one?
On 2-0. And if people disagree, I'm happy to negotiate. But deep perineal muscles, to be deep enough to need a 2.0, we're not going to be doing those. So up above where it says 2-0 gut or synthetic for anal, comma, rectal, comma, or lateral vaginal injuries. Anal, rectal, and then get rid of deep perineal muscle. We'll need to change that on this. And then 3.0 is for most genital repairs, and 4.0 is for fine labial, clitoral, or periurethral repairs.
I'm sorry, I was still trying to correct number 5.16a. So 2.0 gut or synthetic for anal, rectal, or lateral vaginal injuries. And then 3.0 is gut or synthetic for most genital repairs. And then what, Hall?
4.0 for fine labial, comma, clitoral, comma, or periurethral repairs. So for fine labial, look at clitoral, CLITORAL. Or periurethral.
And then the rest of it goes away?
Yep.
Okay.
I think that should be spelled PERI.
It does. PERIURETH. Lots of vowels.
PERIUR. There we go.
There you go.
It's really sad when, yeah, I'm just going to move on past that. Never mind. Oh, goodness. Okay, so we good? I'll renumber. The lower the number, the larger the strand. So all of these are 2s.
Yeah.
Okay. All right. 5.17, explain the differences in the cutting edge and most appropriate use of each. 2s?
2.
Mm-hmm.
Okay.
And really the only one that they should be using is taper. So I don't know if we want to capture that somehow, but.
With a more important question number? No?
The problem is that cutting and taper cutting are for suturing skin, and we don't suture skin. We shouldn't be cutting through the perineum at all. We're only doing subcutaneous. So really all we need and should be using is a taper cut or taper point, and it minimizes risk to us. I don't know if it's enough just for them to know that it's for use on skin for cutting and taper cutting, and thus you wouldn't be using it. But I know people do use taper cut needles, and sometimes they get hurt because they're not good with their instrument in each hand. And so I don't know how people feel about if we should be doing more with that or just not worry about it.
I don't have a strong opinion on it. Yeah.
Okay. Well, when we write these questions, we're going to be using the information that explains what the most appropriate use is, as well as a description. So maybe that will take care of the problem. Once you see the questions, we can circle back around to that.
Okay. So we're gonna leave them at 2s.
Yeah, for now.
Okay. Demonstrate the correct use of a needle holder to make an instrument tie. So 3 because it's on the skills.
Exactly.
Okay, explain the pros and cons of instrument ties. And everybody, well, it was kind of 50-50. 2. Okay. Explain pros and cons of hand ties. We have 3s. Pretty good with that.
Yep.
List steps for first degree. So 52122 and 3 should all be 3s because it's on the skills. Oops. I guess that's no question. Sorry, my bad. Oh, wow. I'm doing good today.
Now 5.23, we have list steps for labial repair. Right now, we don't include that on the skills exam.
So maybe we should have a roll-in question, or should it be a mandatory?
Well, again, we could add it somehow to the skills exam. That's an option, although it's very hard to figure out how to do that because we don't have, you can't use a phone block for that. That's for darn sure. And I'm not sure what we put in, but it's kind of tautological here. What we put in the learning objectives is refer to skills exam for correct administration. So that's not helpful. So it really depends on the situation for that. So I am kind of inclined, is why I gave it a 3. Hard to test for. So what do people think about? I mean, everybody else gave it a yes, and then I gave it a no. So that's why I'm bringing it up. Like, should we be, what should we do with that?
I feel like it's a skill that as a midwife we should know, but it's maybe not necessary when you're first starting out. You know, it's something that you're going to add those skills as you go. So yeah, that one's a hard one. And like, yeah, how do you test on it? Yeah.
Are we moving that to a 3?
Thoughts, Colleen?
I know I'm really kind of back and forth with it.
Yeah.
I mean, it seems like it shouldn't just disappear. It's not on the skills exam and it's not here, then it's really nowhere other than in whatever training that you may or may not take. I don't. 2 at least. Yeah, I don't think I want it to not be there.
Okay.
And I don't know if this is helpful. This is a little thing that I picked up that for doing suturing practice. This could be something that for people doing the testing, they could use. But
is it a thing you actually suture on?
Yeah, it's I haven't used it yet, but you just practice like suturing on it. It's like a latex kind of squishy
You need to
material.
send me one of those so that I can look at it and decide.
Yeah, yeah.
Or send me the information about where you got it.
It's Amazon. Yeah.
Oh, the A word. Darn.
I know.
Okay, 524 explain. So 523, we're going to give that a 2, and then 524 explain how to maintain aseptic technique while suturing.
And here we have things like hand washing, gloving, sterile equipment, sterile field, that kind of stuff.
Put a 2.
Okay, explain the benefits of a running mattress stitch for closure of perineal skin. 2.
2.
Okay. Demonstrate dual instrument suturing techniques and prepare, or excuse, here, let me just start that one over. Demonstrate dual instrument suturing techniques and other practitioner safety techniques.
That'll be
These are going to be 3s because of the.
demonstration.
Those are all the rest, I think, are on the skills exam.
Oh, right, because they're on the skills. Yeah. So it's practical application.
Oops, no question. Here, I just got to get that done. Okay.
Ta-da! I think that's it.
Yay. Okay, so we have a couple options here. One of the things that we thought that we would do is if you could just give us a few minutes, we could actually get you what is going to be the bank of our questions and what our total final number is at this point. We can either do that now and take that 15-minute break, or we can just send it to you and kind of go back and forth individually, or how would you guys like to do that?
The form that you guys use that you showed us at the beginning is really not intuitive to me. I have a hard time understanding that form with the, what I really want to know is how many mandatory and how many optional questions do we have at the end when it all gets added up.
Well, that's what it is, Holly.
But it's
Hang
also
on.
the breakdown on your map, right? That thing. I find that thing.
It's item management. That's what this is, Holly. I know it. Okay, so for example, for drug definitions, Holly, we have 1 roll-in question and 1 mandatory question. So
No, I know.
literally there under definitions, there will be 2 questions.
Right. Yeah.
So under pharmacological.
I'm not sure that it's worth our time for us to go through this list at this point.
Okay.
And wait for him to run that. If people decide they want to do that, we can definitely do that.
Okay.
Is it worth it to you guys to wait for him to update this so we can see for peak side effects that there's 1 + 1 or 7 + 13 or whatever?
I mean, but yeah, what's the point? Like,
Yeah,
to
well,
be-
to get the final number. So here, for example, to see if we have a 200 question test or a 205 question test, and then we can determine whether out of these 13 that are in the bank, if we want to beef this section up, or if we need to, out of this section for the side effects, beef that up to get
me,
a good number.
Until we see how hard it is to write the questions and whether we're going to be able to write the questions on the things that we've indicated, that sounds like fine tuning a little prematurely to me.
Okay.
Because it may be that some of these questions we're going to have to come back to the group and go, we can't figure out how to ask this if we can't put it negatively, if we can't have true false, if it has, all the restrictions on it. We may need to craft some of the questions a little bit as a group and have group think around it. Or we may go, there's no way to ask this in a way that the state allows it to be asked.
yeah.
So that may prune, or we may end up ourselves going, we think we need 2 questions for this because to cover it, so it seems to me, and again, I'm willing to do whatever the group feels is most
that
effective.
sounds, I mean, I think you're right, Holly. I think that's we just wanted to kind of give you a final number, but absolutely, we'll just send it to you where we're at, even though it'll be preliminary, and then we'll start writing questions and just move forward, and then we'll come back in June and then see where we're at. And the final will tell the story of, like you said, with writing those questions and do we need another one or not. And so definitely that's what will happen. So, okay. Yeah, that sounds great. If everybody's good with that.
Everybody else? I mean, am I being overly persnickety?
No, I don't. Well, I don't think so. I mean,
I don't think so. Mm-mm.
we just, we wanted to give you something if you wanted it per se. All right. Well,
I wouldn't mind you sending out an email going, at the end of the day, we ended up with 217 total questions, of which 93 were mandatory or something like, just to have a sense of what we accomplished. But I'm not sure it's worth it to me, not that you guys aren't precious and I don't love every one of you, but to wait 15 or 20 minutes to get those numbers doesn't seem.
Yeah, no, we'll send them out. We'll send them out to you. We'll send them out to you. And by the end of the week, within the next couple of days, okay?
So is
At
Brandon's
least.
feelings hurt now? Are Brandon's feelings hurt?
No, his feelings are hurt.
Okay, we don't want to antagonize Brandon in any way. We want him to be happy, 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 happy.
He was over there working hard for you guys, just so you know though.
Oh, he's so good.
Yeah, he really is good. He's great to work with. So, all right. Well, I'm going to close up the meeting then, and then we'll get that sent out, and then we'll work with you on a couple of things, Holly, that we have to work on, and then we'll send you the paperwork of the. Yeah, I got to figure out how we have to do this for executive session for examination questions. We just may have to go one by one. They may not be able to be sent out, so we'll see how we're going to work that. So, all right, well, thank you, everyone. And then the Board of Direct Entry Midwifery Legend. Oh, I need public comment. Is anyone on the phone? No. Okay, no public comment.
And remind me, when is the next meeting?
It is June 20. Let me look at my schedule. 9th
At what time?
at
10.
yes, 10
10
o'clock. Thank you.
Oh, that's great.
Does that work?
No. Hold on, let me look. I don't think
No.
so. June 29th.
Thursday.
June 29th. It's a Thursday. It works for me until 12:30. But then I have a transfer meeting with our hospital that I won't miss.
No, that sounds super important, Colleen.
But Holly, you had confirmed, and Desi and Catherine and Greg confirmed when we set up this, I believe. Is
That was
everybody
a long
still
time
good?
ago. It's
I'm
okay with
confirming
me.
now.
Would
I'm
it be
sorry, what,
better-
Greg?
What if we start at
I'm
9?
accepting the meeting invitation right now.
Some-
For the 29th?
Yeah.
What about if we started it at 9 or 9:30 instead of 10? Would that work for everybody?
Works for me. Yeah, I just need to be
9:30.
at that meeting at 12:30.
Yeah, starting at 9 works for me.
Okay, and Greg, you were okay with 9 o'clock then as well?
Yes, that'll work.
And
Perfect,
Des?
we will,
Yep.
yeah, I'm sorry, I saw her head shake. So we will change that meeting to 9, and then the other meeting was August 24th. Colleen, are you able to be
Yeah,
at that one?
That works.
And would you prefer I move it to 9 a.m. as well,
No, I
everyone?
don't care. That day's fine, whatever time.
10 a.m. on that day is okay?
Yeah.
Okay, we'll leave that date at 10. Okay, perfect. Then we will see you on June 29th at 9 a.m., but we will definitely be in touch before then.
Okay, thank you.
Okay, so where's my statement that I just lost? The Board of Direct Entry Midwifery Legend Drugs and Devices Qualification Committee meeting is adjourned at 3:26 p.m. on May 22nd, 2023. Thank you all very much for your time. I
Great.
appreciate it.